For decades, women who survived breast cancer were told one thing: avoid estrogen, all of it, even the low-dose cream used for vaginal dryness. The fear was real, and so was the silence. Millions of women suffered through pain, dryness, and the slow withdrawal from intimacy because they followed the recommendation. They did what they were told, and no one came back to ask whether the warning had ever actually been tested at that dose in those women for that specific use. Data presented at the 2025 ASCO annual meeting tells a different story. In a study of 18,620 breast cancer survivors aged 65 and older, the women who used low-dose vaginal estrogen didn't just do fine, they had a 44% lower risk of dying from any cause. In this video, I'm going to walk you through what that data actually shows, what the science says about safety, and the one distinction that changes everything about this conversation with your oncologist. This cream right here, smaller than a tube of lipstick, smaller than anything that should carry this much weight, became a symbol of a decision that millions of breast cancer survivors made in silence. Not because they wanted to, because they were afraid. And the fear wasn't irrational. They were told it wasn't safe. They were told that estrogen, any estrogen, was fuel for the disease they had just survived. So they put it down. They lived with the pain. And nobody came back to ask whether that was the right call. I'm James Reyes. I'm not a physician, I'm a researcher, and I've spent years going through the medical literature on women's health after cancer, partly because of what I've seen happen when fear outpaces the evidence. Nothing in this video is medical advice. What it is the research your oncologist may not have had time to discuss with you yet. Drop a comment right now with your age and whether this has ever come up in your own appointments. I want to see who's in this with me, because where you are in this journey changes everything I'm about to show you. Here's what happened. In 2002, the Women's Health Initiative, one of the largest clinical trials ever conducted on women's health, published findings that stopped the medical world in its tracks.
Hormone therapy, they found, was associated with increased breast cancer risk. The headlines were immediate and unambiguous. Estrogen was dangerous. Full stop. What the headlines didn't explain, and what most doctors didn't have time to parse in the weeks that followed, was that the WHI was studying systemic hormone replacement therapy, oral doses, pills delivering 0.5 to 1 milligram of estrogen into the bloodstream. A whole-body intervention. Nobody was studying the small tube of vaginal cream that a breast cancer survivor might use for the pain and dryness that comes with surgical menopause or aromatase inhibitors. That's a dose of 10 micrograms. The absorption into the bloodstream is minimal, documented by Memorial Sloan Kettering and replicated across multiple pharmacokinetic studies. That difference matters more than most people realize. Think of it this way. A teaspoon of salt in a glass of water is immediately noticeable. That same teaspoon dissolved into a full bathtub is undetectable. The 10 microgram dose in a vaginal cream is not the same intervention as a systemic pill. Not in mechanism, not in absorption, not in what it does in the body. They share a name. They are not the same treatment. But the category collapsed. Estrogen became one word, one risk, one prohibition. And the women who were suffering from genitourinary syndrome of menopause, a condition that affects up to 84% of postmenopausal women, and more severely in those treated with aromatase inhibitors, were told, nothing we can offer you is safe. Let me say this carefully, because I want to be precise about what I'm describing. This wasn't a conspiracy. It wasn't negligence. It was a structural failure of how medical evidence moves through a system built for speed. The WHI results were real. The extrapolation to vaginal estrogen was not evidence-based. And it took more than 2 decades and multiple large studies for that to be formally recognized. In my view, this is one of the most costly gaps in women's oncology care in the last 20 years.
Not because the intention was wrong, but because the silence had a price, and that price was paid every day by women who had already been through enough.
And that gap between what the research now shows and what millions of women were told is the reason this conversation needs to happen. If the warning you were given about estrogen was based on a study that wasn't testing what you were being warned about, what else might have gotten lost in that translation? What I found when I went back through the literature, and I've spent the last several weeks going through this systematically, is that the research on vaginal estrogen in breast cancer survivors has been building quietly for years, and it's now reached a point where the evidence is not just reassuring, it's striking. That's where we're going next, starting with the study that changed how the medical community is looking at this question. The 2025 ASCO annual meeting is where cancer research goes when it wants to be taken seriously. Thousands of oncologists, researchers, and clinicians from around the world gather each year to present the findings that are going to shape treatment in the years ahead. And in 2025, a study was presented there that I believe belongs in every conversation about breast cancer survivorship care. The dataset was the SEER-MHOS, the Surveillance, Epidemiology, and End Results database linked to the Medicare Health Outcomes Survey. 18,620 women with a history of breast cancer, all aged 65 and older. Of those, 800 had used low-dose vaginal estrogen. The researchers followed outcomes across both groups. The results were, and I want to make sure I say this right because the number matters, statistically significant and clinically meaningful in both directions. Women who used vaginal estrogen had a hazard ratio of 0.56 for all-cause mortality. For those not familiar with how hazard ratios work, a hazard ratio of 1.0 means no difference. Below 1 means lower risk. 0.56 means a 44% reduction in the risk of dying from any cause compared to women who didn't use it. But the number that stopped me, the one I keep coming back to, was the hazard ratio for breast cancer-specific mortality, 0.53. A 47% reduction in the risk of dying from breast cancer itself in women who had used the vaginal estrogen. A woman who had survived breast cancer, who used a low-dose topical cream for vaginal dryness, was 47% less likely to die from that same cancer than a woman who didn't use it. Nobody told you that. Think about what that means in practice. Picture a woman in her late 60s. She finished treatment 3 years ago, surgery, then aromatase inhibitors, then the long, slow work of surveillance. She goes to every appointment. She takes every pill on schedule. She has done everything right. And every morning she wakes up with pain that makes the most ordinary parts of her life, getting dressed, sitting at her desk, being close to the person she loves, feel like something she has to get through, rather than something she gets to have. She asked her oncologist about it once. The answer was quick. We can't use hormones, you know the risks. She didn't push back. How could she? She had just survived cancer. The last thing she wanted to do was argue about a cream. That woman is the subject of this data. She is the 800 women in the SEER-MHOS cohort who used vaginal estrogen. And the finding is that she was not just doing fine, she was surviving better than the women who said nothing, took nothing, and suffered in silence because the system never gave them a different option. Has this come up for you or for someone close to you? Drop it in the comments. I read every one. Now, I need to walk through what this finding is and isn't because the interpretation matters as much as the number. This is an observational study. The women who used vaginal estrogen were not randomly assigned to use it. There may have been selection factors. Women who were healthier, who had more access to specialized care, who were better supported in their survivorship, that contributed to better outcomes.
The researchers accounted for this in their analysis, but no observational study can fully eliminate confounding. What this study tells us is not vaginal estrogen cures cancer. It tells us that in a large real-world population of older breast cancer survivors, use of vaginal estrogen was associated with significantly lower mortality, and that this finding is strong enough and consistent enough to warrant serious attention.
Let me be specific about why the study design matters here and why it doesn't invalidate the finding. A randomized controlled trial would be the gold standard. That study has not been done, in part because researchers have been reluctant to conduct it, given the decades of concern about estrogen and breast cancer. What we have instead are large, well-characterized observational cohorts, real women, real decisions, real outcomes, followed over years. The SEER MHOS database is one of the most rigorous population-level datasets in oncology research, and the consistent direction of findings across multiple independent datasets, different countries, different methodologies, different time periods, is exactly the kind of convergence that moves evidence from interesting to clinically significant. And the reason this finding is not a statistical anomaly is that it doesn't stand alone. Before I get to the part that changes everything, the part that most videos on this topic get completely wrong, I need you to hold what you just heard, because the next layer of evidence is what makes this impossible to ignore. Now here's where it gets counterintuitive, because the ASCO 2025 study I just showed you raises a question that almost nobody in this space is asking, and the answer to that question is the whole point. If vaginal estrogen was genuinely driving cancer recurrence, if the fear was correct, the survival advantage I just described would not exist. You cannot simultaneously have a 47% reduction in breast cancer-specific mortality and a meaningful increase in cancer recurrence. The data would not allow it. Write this down. The question isn't whether the data on survival is real. The question is whether the mechanism that was used to justify avoidance, local estrogen absorption driving tumor growth, was ever actually demonstrated at these doses in these women. And when you go back through the literature, the answer is striking. A systematic review and meta-analysis published in the American Journal of Obstetrics and Gynecology in March 2025 pooled data from 24,660 breast cancer survivors. The odds ratio for cancer recurrence in vaginal estrogen users was 0.48, a 52% reduction in recurrence risk compared to non-users. Let me say that number differently, because statistics can feel abstract when they shouldn't be. 52% reduction in recurrence risk in a meta-analysis of 24,060 women, published in a peer-reviewed journal in 2025. That's not a marginal finding. That's a consistent, large magnitude signal in the direction opposite to what the fear predicted. A Danish cohort study published in JAMA Oncology, 8,461 women with breast cancer, found that users of vaginal estrogen had 22% lower all-cause mortality compared to non-users, hazard ratio 0.78. And a systematic review published in the Brazilian Journal of Gynecology and Obstetrics in July 2025, analyzing data from 118,669 breast cancer survivors across multiple studies, found no increased risk of recurrence or mortality in users of vaginal estrogen therapy. I want to pause on that last number for a moment. 118,669 women. That's not a small study. That's not a preliminary signal from a handful of cases at one institution. That's a systematic review covering more than 100,000 breast cancer survivors. And the finding, consistently across that entire population, was no increased risk. The myth was estrogen, even locally applied, was dangerous for breast cancer survivors.
The data is, across tens of thousands of women, local vaginal estrogen was not only not increasing recurrence, it was associated with better outcomes.
In November 2025, the American Society of Clinical Oncology issued a statement on the HHS revision of the black box warning for hormone replacement therapy. The position was clear. Low-dose vaginal estrogen is a valid option for women with genitourinary syndrome of menopause after failure of non-hormonal lubricants. This is not fringe research. This is the leading oncology organization in the United States in 2025, formally recognizing that the blanket prohibition on vaginal estrogen for breast cancer survivors was not supported by the evidence. If the standard advice you were following was based on a warning that the leading oncology body has now formally reconsidered, who was responsible for telling you that, and did they? That number, the shift in ASCO's position, is the reason why the standard advice that your oncologist may have given you years ago may now be worth revisiting in a new appointment. Here's what that conversation should look like. You now know something most women walking out of their oncologist's office this week don't know. The question is what you do with it. Here's what I do. Confirm the path forward. The benefit here is real, and it's achievable, but only through the right conversation, with the right physician, with the right information in front of both of you. So let me give you 3 things to bring to your next appointment. Step 1. Confirm you have genitourinary syndrome of menopause, GSM. This is the medical term for the cluster of symptoms: vaginal dryness, painful intercourse, urinary urgency, recurrent UTIs that affects up to 84% of postmenopausal women and is more severe in breast cancer survivors on aromatase inhibitors. If your doctor hasn't used this term with you, bring it to the appointment. GSM is treatable. You don't have to normalize it. Step 2. Bring the distinction between local and systemic estrogen and confirm it appears at least twice in this conversation. Low-dose vaginal estrogen at 10 micrograms operates locally. The systemic absorption is minimal, a fraction of what an oral pill delivers. This is documented. The Women's Health Initiative was studying systemic therapy. That is a different intervention at a different dose with a different mechanism. Your oncologist may know this.
Ask them to confirm it specifically for your treatment history and hormone receptor status. Step 3. Bring the ASCO 2025 data and ask the specific question, not "Is estrogen safe for me?" which invites a blanket response, but this: given the ASCO 2025 data on vaginal estrogen in breast cancer survivors, Abstract 578, the SEER-MHOS study, am I a candidate to discuss low-dose local estrogen as an option for GSM given my hormone receptor status and current treatment? That question forces a specific, evidence-based response. It signals that you've done the research, and it opens a door that may have been closed, not because your doctor wanted to keep it closed, but because nobody had given you the key. Important. Who should approach this with caution? If you have hormone receptor positive breast cancer, ER+ or PR+, this conversation requires specialized oncological guidance. The data is encouraging across the full population, but your specific case, your receptor status, your stage, your current protocol determines what's appropriate for you. The absence of a blanket prohibition in the research does not mean every woman's situation is identical. If you are currently on aromatase inhibitors, bring this specifically to your oncologist because the interaction between aromatase inhibition and local estrogen is exactly the kind of nuance that general research reviews may not address for your individual case. Nothing I've said today replaces that conversation.
What I've done is give you the language to have it. What's the one question you've been carrying about your own survivorship care that you haven't asked yet because you didn't know you were allowed to ask? You are not a passive recipient of medical decisions. You are an informed participant in your own health, and you now know exactly what to do next. Recap. 3 things from this video. 1. The fear around vaginal estrogen in breast cancer survivors was based on data from systemic therapy, not local treatment. 10 micrograms vaginal versus 0.5 to 1 milligram oral. Not the same intervention, not the same risk.
2. 4 independent studies, including a meta-analysis of 24,060 patients and a dataset of 118,659 survivors, found no increased recurrence risk and associated low-dose vaginal estrogen with significantly better survival outcomes. 3. The American Society of Clinical Oncology formally recognized low-dose vaginal estrogen as a valid option in November 2025. This is current evidence from the leading oncology organization in the United States. If you're walking away from this video differently than you walked in, drop "informed" in the comments. And a note, because I want to be honest with you, I'm not your doctor. I am the person who reads this research every day and who believes deeply that being informed is not optional. Nothing here is medical advice. These are evidence-based findings that belong in your next conversation with your oncologist, alongside them, not instead of them. If this is the kind of research you want to keep seeing, the subscribe button is right there. I don't post every day. When I post, it matters. There's one more layer to this that I didn't cover today, and it changes how you interpret everything I just showed you. The question of what happens when you factor in the type of breast cancer, hormone receptor status, treatment duration, timing after diagnosis. That's the next video. Don't miss it. What would you do differently in your next medical appointment if you walked in knowing that the warning you were following may not have applied to the specific treatment you were avoiding?